do this kind of thing.
Great. Okay, well, why don't we make a bit of a start? I'm hoping those people who are joining online, if there's any issues with the sound, please let me know. I'm assuming that everything's working fine unless I hear otherwise from you. So welcome to those online and to those in person here in Bristol to a seminar here welcoming a guest visitor. So my name's Jess Watson. I'm a GP and academic at the University of Bristol, and I'm working on a project looking at access to test results, and we've been collaborating with Dr Andrea Bradford, who's here visiting us in Bristol and also coming for the CAPC conference tomorrow, so might see a few more people in person then. So Andrea is a clinical health psychologist and associate professor in the Department of Medicine at Baylor College in Houston. And she's going to talk to us today about patient-centered test result communication in the era of high-tech, low-touch considerations for optimizing patient portals. And this is really relevant for us in the UK because I think the US has got much longer history of allowing patients direct access to their test results via these sorts of online portals. But over the past couple of years, this is something that's been growing in impetus and momentum with portals such as the NHS app and other providers now allowing the vast majority of patients in England, not yet in the devolved nations, but in England, access directly to view their own test results. So I'm hoping we'll have a lot to learn today. So I'll welcome Andrea here and just make sure I get her slides on. I'll bring your slides up for you here. Great. So to move it, I think you just... yeah, you can just click on the arrows. Great. Over to you. Thank you.
Thank you so much, and thank you for having me. It's an honor to be here, and I'm looking forward to talking with you about this topic because it is evolving, even in the US, where, as Dr. Watson mentioned, there has been some history with using direct access to patient test results, some of that driven in large part by policy changes in the United States. And I'll speak a little bit about that just so you can kind of understand a little bit more about where I'm coming from. First, some disclosures. These are the sources of my current research support. I also receive some funding from other sources as well. No conflicts of interest to declare, however. But I do want to share a little bit about where I'm coming from with this topic because there are a few different experiences that I've had, and also living in the US gives me a slightly different take on this topic. So I want to, just disclose a little bit more about my background. First of all, I am a patient safety researcher. I work with a team at Baylor College of Medicine in Houston, Texas, that is devoted to improving patient safety, primarily through improving diagnosis. One of the sort of low-hanging fruit topics in diagnostic safety is improving follow-through and closing the loop on test results. Test results continue to be missed in the primary care setting and other settings as well. Patients can be part of that loop closure, and by keeping patients better involved in that communication loop, we believe that it's possible to also improve upon test result follow-up. Missed test results are a preventable cause of diagnostic delays and missed diagnoses, and we've done several studies to understand how best to engage information technology, especially as a tool to detect and learn from these missed opportunities in diagnosis. So that is one place I'm coming from. Another place I'm coming from is my background as a clinical health psychologist. I do practice as a psychologist, and I work primarily with patients who have some type of ongoing chronic medical condition, often of a fairly serious or lasting nature. Many of my patients currently have digestive diseases such as ulcerative colitis, Crohn's disease, severe reflux, IBS, etc. And I'm interested not only in how living with that disease affects patients' well-being, but also the effects of interacting with the healthcare system regularly. And one thing that I wasn't necessarily prepared for in my training was how often patients would come in distress, not about how much pain they're in or how their disease is affecting their quality of life, but rather how upsetting it has been to interact with the healthcare system in some way and the disappointments that brings. So I've long been interested in the idea of iatrogenic harm, and I certainly see it in my day-to-day practice. And it's another lens that I bring to this one. And then finally, as I mentioned, I'm from the United States. Our healthcare system is obviously quite different. The issues related to test result access and direct access to all aspects of the medical record has been driven in large part by two policy changes that have happened in the past 2 decades. One is called the High Tech Act, which created financial incentives for hospitals, medical practices, other healthcare organizations to adopt and use electronic health records. So the passage of this act incentivized a lot of practices to finally move from paper-based or partial paper-based records to fully online electronic health records. And in order to meet criteria for the financial incentives, they had to engage in what we call meaningful use, meaning that you have to use electronic health records in certain ways to perform certain functions of healthcare. So we moved all of our data online, essentially. We moved all of our data into these large record systems, which tend to be concentrated into a small number of very large vendors who have driven a lot of the innovations and work to design these interfaces. The other policy change is something called the 21st Century Cures Act, which was passed in 2016, and it contains a lot of things, a lot of content that's not really related to this topic. But one provision it does make is that healthcare organizations can no longer do anything to impede the flow of electronic information, including patient access to health information. And in order to comply with that provision in the law, what happened in effect is that healthcare organizations would simply make information available to the patient as soon as it was available to clinicians in the electronic health record. The law doesn't say you have to send patients their results right away, but in practice, in order to comply with this, what we call the information blocking rule, that's essentially what most healthcare organizations do now. And so in effect, some organizations had been early pioneers in allowing patients to access their medical records in real time as they're being updated, but this brought the rest of the United States over to that practice. And you can see here the results of those policy changes. So there's been sort of a steady upward tick since in the past 10 years in the number of patients, the proportion of patients who are offered access to an electronic portal to view their medical records, to review their health information, including test results. But you can really see here that bend around 2020, 2021, when more patients are actually using a patient portal, and that's been a meaningful increase. And two things happened during that period. One, obviously, the pandemic happened, and so we moved to telemedicine, and in doing so, more patients became engaged in the platform as a means of accessing telehealth services. But two, January of 2021 is when U.S. healthcare organizations needed to be in compliance with that information blocking rule. So by 2021, healthcare organizations in the U.S. that used electronic health records needed to make access to those records immediately available to patients in order to comply with federal law. So there have been kind of competing pressures, and the pandemic really was one of them, but competing pressures that have resulted in patients now using patient portals to an unprecedented degree. In keeping with that, we've also seen a larger proportion of test results being viewed by patients before the clinician who ordered them has had an opportunity to review those results. So these come from an oncology setting. And as you can see, again, this bend happens in about 2020, where all of a sudden there's a large increase in the proportion of test results that patients see before the ordering clinician has had an opportunity to review them. And this is data from one kind of large integrated health system. So you can see the numbers here in the millions here, but these are test results. And I'm going to walk through a little bit what these data show on this display. On the left-hand side, you'll see a before and after of how many, the proportion of results that were reviewed first by the patient before the clinician saw them. In that category of test results that this organization had already been releasing same day. Essentially, this organization was an early adopter of immediate test result access. Not a whole lot changed until they actually made a policy shift to not automatically notify patients that they had new test results. And I'll talk a little bit more about that later because that's an interesting shift in their process. But over here on the right, these represent test results that were delayed in their release for up to 14 days because of their sensitivity. So this would include things, for example, like the test results for STI testing, for instance. They used to be on a time delay. After implementation of the Cures Act, they were no longer delayed in their release. And so all of a sudden, again, you see this proportion of like about half or so of these results being viewed by patients before the clinicians got to them. And again, these numbers are in the millions. So this is happening, this is ongoing. And again, there's this bend right around when this information blocking rule went into effect. Okay, so with that as a backdrop, the couple of things I would like to do today are to describe some previous research findings that can help to inform patient-centered communication of test results. We've learned a lot through this natural policy experiment that we've had in the US, but others have been studying this in a specific way for over a decade. And I'd also like to talk about 3 different perspectives or lenses or frames of reference from which we can evaluate how this access to test results is being implemented and how it's being received by patients. I'd like to back up a little bit and talk a little about some historical context for this whole conversation. We'll continuously see the topic of cancer coming up. So we're just going to start there with cancer because that's the thing that many people bring up and are concerned about when we talk about immediate access to test results or to other health information in the medical record for that matter. But in the 1950s, a debate at the time was whether people with cancer should be told about the diagnosis at all, whether patients should have access to the diagnosis in itself. And you see a range of perspectives on that, but I think that the one up at the top here is pretty standard, pretty commonly reflective of the time. And this is just a quote from this article. Do cancer patients want to be told that the problem of whether or not the patient has the problem of whether to tell the patient they have cancer is an old one? It frequently involves philosophic and psychological consequences of extreme complexity. So it's so fraught, and it's really framed as being extremely fraught. And I don't think that many people in 2025 would think of it that way. But again, this is the debate at the time. Although that wasn't a uniform view, there was a study in 1959 by Aitken, Swan, and Eason, who actually did a radical thing. They actually interviewed patients shortly after they were diagnosed with cancer to see how they felt about it. And interestingly enough, the majority of patients actually supported doctors telling the patient about their diagnosis. About 19% of the patients in this study said, no, I haven't been diagnosed with cancer, which the authors interpreted as denial, but I don't really know. It may have been a very subtle way of trying to break the news and maybe didn't get through the right way. But only, I think about 6% of patients in this study, interestingly, all women, said that they regretted and didn't support receiving the diagnosis. So this is 1959 when we're talking about should patients have access to this information, and patients are largely saying yes. And we kind of see this whole debate revisited in the debate about whether patients should be able to access their medical records. Do patients own their medical records? Do they have a right to review and perhaps amend their medical records? And the prevailing view at the time And this would be like the 1970s, 1980s, typically. The prevailing view would be, we'd really rather send it to the physician, have the physician interpret that information to the patient, answer the patient's questions, but essentially act as a buffer or a filter rather than allow the patient to directly receive the chart. So there's still this stance of gatekeeping. And even though by this point in the United States, several states had passed laws requiring healthcare organizations to provide patients with their medical record if they asked for a copy. But there were many lawsuits because many healthcare organizations just didn't do that. So that is another battle that has been sort of waged over time. And here we find ourselves today with the issue of test access. And so again, I'm using pull quotes here to kind of summarize some typical views. And this one coming from a very recent study, actually just published in 2025, in terms of actually disclosing medical reports that are written in medical language with the intention of being a communication tool between healthcare providers. It just creates unnecessary anxiety. It's just too anxiety provoking for the patient. And what if they are all by themselves at home reading this information? What will happen to them? I'm not trying to minimize the concern, but I am reflecting that this is not a new question of whether patients are able to manage their own reactions to their health information. It's just in a new format with new technology and maybe a little more specific to that issue of real-time test result release. In the United States, I think that there's still a large proportion of physicians who would prefer something more like a graded release of information, especially for test results indicating a life-threatening condition, for example, so that there is that element of gatekeeping. There is still that element that the clinician can put on the brakes, maybe delay the release of that test result to the patient, just provide a little bit more of a cushion. I think that's still a view that even though it's not, it doesn't really follow the law, that is a view that I think a lot of providers still embrace. And there is a mechanism in the law if we have a true reason to believe that an individual patient may be harmed by release of information. We can still block that information. There is a provision in the law that there are several exceptions. So for example, if I know that I have a patient who is controlled by an intimate partner and may be subjected to violent behavior, if the partner who has access to that person's record is able to see that, I can block that information because I have good enough reason to know. I have to document that reason. I have to stand by it. But there are some mechanisms when we truly feel that a patient would be endangered by that immediate release. But in general, in blanket terms, it's just no longer an option. And it's opened up this again, very interesting natural policy experiment. And so I'd like to also share a couple of views from patients because patient attitudes differ as well. So patients may say something like, let's say a doctor runs a test and it's something kind of sensitive or maybe something impactful like suspicious for cancer. I would just like a call to come in and schedule and talk about it. I don't want it pushed out to me. I don't want to force down my throat on the portal before I've had a chance to talk to my doctor. Whereas many other patients will say, no, it's my information, it's my body, and then come what may, I'd like to see it as soon as the doctor sees it. So there's some differences among patients as well. But there have been some larger surveys that I'll speak to in a moment, showing that for the most part, patients do want the access, even if they don't personally want to access it right at the time, every time. So most of a good bit of what I'm going to share today has been covered in a scoping review that we completed and published in 2024 on behalf of the Agency for Healthcare Research and Quality. We published this review as part of a larger contract to develop resources and tools to support diagnostic safety in healthcare. So we conducted a scoping review. We found 125 English language publications. We really tried to date things since the passage of the Cures Act to kind of keep this contemporary. So it only goes back to 2017. But we included anything that described patients' behaviors, attitudes, et cetera, around receiving test results directly through a patient portal. And we also conducted, as a supplement to that information, some interviews with clinicians, health informatics experts, and folks who are in federal policy type roles to get some additional perspective and background. And I'll speak to that a little bit as well. But throughout the talk, as I kind of go and describe this review, I'm going to refer you back to this review. You can certainly access it at the QR code, but there are some findings that are supported by half a dozen studies or so. I'm not going to list every one of them. I'm going to refer you back to the review in some cases. I will say also that one caveat is that most of these studies were US based. And actually, if we then broaden that a little bit to North America based, US and Canada specifically, then that number increases, that proportion increases to about 75% of these studies. The primary modes of data collection were surveys and interviews, although there are some observational studies that provide some interesting insights into what patients actually do with their health information. Okay, so the first lens that I'd like to speak to when evaluating how this is working is the patient experience, which I think we should float to the very top when we're evaluating any type of health service or health program. And I'll say this question out loud. Why should patients be able to access their test results directly? Because it's not always obvious, especially for those of us in healthcare roles who feel that, we have a good thing going and are good gatekeepers. But patients use this. Patients use their patient portals to access test results almost more than anything else they do with a patient portal. We found 15 studies that listed various features and had patients rank them or say how frequently they use them, or did they or didn't they use these features of the patient portal. And 14 of those 15 studies looking at test results was the #1 or #2 most frequently used feature of the EHR. So if you provide this, patients probably will use it. And just to give you an example, this study actually came out a little bit after the period of our scoping review. But these are 465 Americans recruited from that most American slice of life place, a county fair, by researchers in a federal health agency. And these folks were asked, do you use a patient portal? Okay, 465 people who did use a patient portal were asked to indicate which features that they used, and over 90%. The most frequently used feature was viewing their lab results online. So if you build it, they will come. And in a pretty large survey, over 8,000 people in 4 geographically distributed academic health centers, 90% of patients indicated that they actually prefer delivery of their test results through a patient portal. They might also like a phone call from somebody at their doctor's office, but they like being able to have that information available to them. There was also a subset of those patients who were specifically asked about having received a result that was not normal. And almost all of them indicated that even though maybe that caused a little worry or concern, they still would prefer to have real-time, immediate access to those test results, even those that are not normal. And so this is what patients want. This is what patients prefer. And, again, we started to implement this as a country about 5 years ago. And over that time, we're seeing a general trend toward more patients using the test result viewing feature of their patient portal. Less and less time elapsing between that result hitting and being finalized by the lab or imaging department and a patient seeing it, and a larger proportion, as I spoke to earlier, of patients viewing those test results, more and more test results being viewed first by patients and then by healthcare providers. Patients also, again, like to hear from their doctor. What they don't like is having to wait. And so patients will trade off. Patients will get the information through the portal, expecting that at some point they'll see their doctor, but they would prefer not to wait. And the delay is one of the factors that influences patients' attitudes toward the portal the most. The other is the sensitivity of the result, with some patients preferring to have that personal conversation so that a concerning test result can be put into some context. But if you look even at literature outside of the US, for example, the study of over 4,500 patients in the Netherlands, still there is a staged release. Their law, I don't know the ins and outs of it, but their law doesn't require immediate release. And so results are released on a certain delay, depending on the type of result and so forth. When patients in this study were given an option, do you want to delay by a day? Do you want to delay by 7 days? Or do you want to delay by 7 days versus 14 days for more sensitive results? The majority of patients chose the shorter delay. And even over the course of that study, about 10% of patients actually changed their notification preferences. And most of the people who did change opted from a longer delay to a shorter delay. So the lack of delay is really the big draw here. However, as one of the folks we interviewed told me, patients don't want it shoved down their throats, so to speak. Patients may not like the push notification necessarily. And actually at the Vanderbilt University Medical Center, I understand that patients were part of the driving force behind turning off the default setting in the patient portal so that patients were not automatically notified unless they opted in to be automatically notified every time a new test result hit the portal. So the medical center switched off that default test result notification, pushed out a message saying, hey, we've switched this off, but if you want to be notified every single time a new test result is available for you in the portal, just switch it back on and you'll receive those push notifications once again. But only 42% of patients who did receive test results actually opted for that. So patients want test results when they want them. They may not necessarily want it pushed out to them, and maybe we just get too many notifications, and that's part of it. But in any case, that was an interesting kind of natural experiment. And again, that my understanding from talking to some folks involved in that policy decision was that patients were part of the driving force behind that. They wanted to be able to, when they were ready to see their medical record, to go in, but not to be prompted externally to do so. Another reason why patients should be able to access their test results directly is because when patients are more engaged and active in their patient portal, that tends to align with improved adherence. Now, is that a causal effect? We don't really know. The data don't support causality here, and it's very likely that patients who are active users in their patient portal are already more activated and already are more engaged in their own healthcare. But what we do know from other studies of patients who look at their patient portal for clinical notes are that they no-show less often than patients who don't use the portal at all. And also patients who use the portal and read their notes were more likely to follow through on their doctor's order for a medium to high risk evaluation for a colonoscopy or a dermatology consultation for a concerning skin lesion or a cardiac stress test. Those were the 3 tests that were the focus of that particular study that is referenced in reference number 1 there. And just to give you a little more context about that, here is a graph showing the proportion of those orders and consults that were completed. And this is stratified by whether the patient didn't use a portal at all in the darkest gray bar, whether a patient used the portal but had never read a note in the portal, which is the light gray bar, and then the white bar represents the proportion of patients who were both portal users and had read at least one clinical note and actually accessed them. And so in order to do this study, this is an interesting side note because it raises the importance of being able to use metadata in the EHR to kind of track what patients are actually doing. It's important to involve patients in the design process for portals. It's important to survey them on their attitudes, beliefs, their preferences, but it's also important to see what's actually happening because it doesn't necessarily align. And just like all of us, we don't really know how we're going to behave in a given situation until we're in it. And since this technology is here, we didn't necessarily ask for it, but this is what we do with it now that we have it. Patients perceive a lot of benefits, though, to this technology. They think it saves time, makes it faster to do what they need to do. They like being able to access information, again, on demand, when they want it, how they want it. Patients in survey research and in interview research have described feeling more engaged in their own healthcare, better informed, more activated, and less of a need to rely on others to provide that information, which again may incur delays, inconvenience. It's just easier. And also patients have raised that being able to access that information directly also helps them feel safer because they are more in that loop. Finally, and this is much more of a proposition or a hypothesis, but another reason to engage patients in accessing their results is that when you do it well, it can actually empower and activate patients. And I'm going to be a little bit contrarian here for a moment and share a couple of instances where two patients learning about, or two situations in which patients learned about a cancer diagnosis through their patient portal, and that actually turned out in these cases to work out well for them. So in one, this was someone we interviewed for our scoping review who said, I've had people tell me they found out they had cancer via NIHR, one of the patient portals in the United States. And what those patients have told me is that the opportunity to get the news in private, to cry, to grieve, to kind of collect themselves, come up with questions, and then use that next visit as a more productive step, helps them feel more empowered. So they weren't there getting the diagnosis and then it was sort of deer in the headlights. They sort of had time to work through that before. And the other quote is something similar. And I promise these are not the same two people I checked. But the idea is that, perhaps the doctor's office may not be the most comforting space in which to receive bad news. Maybe it's not as critical for every patient to be in a clinic to learn that when they learn that they have cancer. And we should honor patients who prefer that. And also we should make allowances also for patients who really do want to be with their clinician to talk about these sensitive results. And part of the problem, which I will address later as well, is that right now our systems are sort of one size fits all in the US, and we don't allow for that customization. And that's one of the limitations that both clinicians and patients see, because clinicians see this too. This quote on the left was followed immediately by a caveat that one patient is one patient, and this isn't going to work for everybody. In this case, this was good for the patient, but it won't always be that way for every person. But when we do this well, we can not only inform patients about what's going on with their health, but we can also educate them about why this is important and what this means, and hopefully activate patients toward taking that next step in their health. And so I'd like to share a little bit later on about how we can leverage psychological theory to think a little differently about using test result communication as a health promotion tool. Let's start with a very common framework, the health belief model, which posits that people take action related to their health to protect their health, or maybe actions that may put their health at risk based on a variety of beliefs and thoughts or perceived barriers in self-efficacy. So in order to make an informed decision about your health, you have to have a sense of how much of a threat it is to you personally. Is this something that is going to happen to me? Is this something, is changing my behavior or engaging in a health behavior going to benefit me? Is it of any use to me as, let's say, a 40-year smoker to quit smoking, for example? We have to believe, A, that something bad is going to happen to us if we continue, and B, that there's some benefit to quitting in order to move toward that health behavior. Perceived barriers to the health behavior, like it's too difficult, it's too much of a pain, I can't do this, I can't, I can't interpret what this is saying to me, etc., are also important aspects of that decision to engage in a health behavior and the ability to actually do so. And so we can think about these in the context of accessing test results, in the context of being engaged as a partner in your own care by sharing that information, by being a co-steward of your health information that you're also managing alongside your doctor. And so in order to move toward this, this behavior, all of these things, all of these criteria need to favor engagement. And so I'm just going to give you an example of how this can play out in the study. This was a study it's a smallish study, but a study of about 20 or so patients who had a transplant. These were folks who were fairly well engaged in their care already. But the idea was that, well, let's show their test results to them in a way that is going to, perhaps make it more clear how urgent or how necessary it would be to take action on these steps. Let's make the abnormal results red, the good results green, et cetera. Let's look at some graphs and charts. And then the researchers in this study asked, well, what would you do if you were presented with this information? Would you call your doctor right away and ask for an appointment? Would you just wait for the next follow-up, et cetera? And based on their responses, they were kind of classified into whether they perceived the results to be more high risk, low risk, or somewhere in between. And about 2/3 of the patients in this study really kind of underestimated how urgent the action was that needed to be taken. And so what that really drives home is that it's not just enough to inform. We also have to do things that are going to help to educate and activate patients in order to steer them toward the right course of action, or to recommend the right course of action, because it's not necessarily going to be obvious from just the test results alone, even if we display them in a way that helps facilitate that interpretation. Okay, so I'm going to talk now about the next lens through which we can think about evaluating test result access, that of usability and equity, and those things kind of go hand in hand. I'm going to make a brief nod to my mentor, Hardeep Singh, and his colleague, Dean Siddig, who proposed a socio-technical model, which can be used as a health information technology implementation framework. And the model essentially proposes that we have to take into consideration all of these different facets of health IT implementation, not just the hardware and software, but also what is the information we're putting in? Is the clinical content up to date? Are we using, modern reference ranges and things like that? How effective is the human-computer interface? Who are the people involved, and what are the workflows and communication patterns that make this work? What are internal and external pressures on the organization to take action? And how are we monitoring the use of health IT to make sure that it is indeed safe and effective? And so this is a lens for thinking about implementation and actual use versus intended or anticipated use. What we see in the literature, and this is one of the most robust findings, is that folks who are older tend to use patient portals less often than younger populations, and that extends to looking at test results specifically. So there have been some studies that have broken down different features of the EHR portal and found that older age really kind of across the board affects use or is associated with less frequent use of these features, including accessing test results. We've also found that certain social vulnerability factors seem to be related to less frequent use of test result viewing in the portal. Another fairly robust finding in the US has been also that use of a primary language other than English, other than the dominant language of the health service organization, is also associated with less access and disparities in patient portal use. When patients actually are asked to talk about the usability of a patient portal, the usability concerns are often focused around not really understanding what the medical terminology and the lab values mean. Obviously, lower health literacy is going to compound that difficulty, and it can be a potential solution to include both data visualizations and plain language summaries that can help a patient to put that into better context and to better interpret that information as it applies to them. Now, there was a study done in the Netherlands in 487 participants who were given some mock test results and asked to rate their level of engagement, which in this study also kind of address some of the emotional reactions or the feeling of kind of being overwhelmed by the information. And in this study, I'll go back to the other point, but in this study, they compared two different ways of showing test result data. So the one on the top above the line shows just a very basic table with just basic lab values, really not much interpretive information. And then the bottom is this more patient-oriented summary that includes things like color coding so that you can have some interpretive context. This range at the bottom, kind of showing a little bit more context to help you place your result in a range of what's normal and abnormal, and an explanation of what this thing is that we're measuring and why it's important, why it matters. And so patients who received the more patient-centered version did not have as overwhelmed reactions and were more engaged than patients who just received the table. But it's interesting because when you actually go to design and do usability testing on these different interfaces, you uncover all kinds of things that you wouldn't have anticipated, which is why it's really important to involve patients in the design of these interfaces and also do formal usability testing. And I can recommend to you this paper by Nystrom et al. Because it really describes, they're very quite honest about things that they discovered that they didn't anticipate when they actually went to do formal like cognitive testing and other usability testing patients. Patients in multiple studies have made suggestions for how to make patient portals more usable, how to make test result access in particular more helpful to them. And healthcare professionals have weighed in as well. And what's interesting is that when you really collect these studies and start to look at overlap, patients and healthcare providers want many of the same things. They want those visualizations to support interpretation. They want plain language summaries that make the test result more interpretable and actionable to patients. They want take-home messages. Again, just like that study I showed you earlier, it's not enough to just show the patient what the result is. It's not even enough to show the patient that they have an abnormal result. It's what do you do next? What is the urgency here? Do you need to call and make an appointment right away? Or is this something that you can discuss at your regular, 3-month follow-up or whatnot? That take-home message needs to accompany the result because patients are not necessarily going to have the same interpretation of the severity. And then finally, notify patients according to how they prefer to be notified or whether they prefer to be notified. And a small minority of patients are not going to want to see it. They're going to want to know, they're going to want to hear it directly from the doctor. This is not complicated engineering to make that happen, right? It just needs to happen. Now, where patients and healthcare providers diverge is patients want to know, has the doctor seen this result yet? Which is really an interesting finding because If they are thinking, why haven't I gotten a call? But then they can log in and see, okay, well, the clinician hasn't even reviewed it yet. I got to it first. That may help to provide some reassurance. To also tailor that information, not just to create that lay summary, but maybe to tailor it even a little bit more to a patient's health literacy. And also patients want access to the images themselves. They want access to their x-rays, CT scans, et cetera. Healthcare professionals, not so much. They don't, no one really on the healthcare professional side said that, but patients want everything, typically. Healthcare professionals felt that it was also important to provide that kind of clear point of contact, again, kind of related to the take-home message piece. But if patients do have questions, how can we make sure that they get to the right person? So these are some kind of action steps that both patients and healthcare professionals have recommended in multiple studies. And for the specific citations, I refer you to the scoping review. A final lens through which we can think about the issue of test result access is patient safety and unintended consequences or harms. The thing that comes up most often in the literature is this is going to make patients very distressed and anxious. The problem is that studies that have looked at this don't really differentiate temporary anxiety from the kind of distress that can cause more long-term changes in emotions and behaviors. I'm not aware of any study that really looked at whether patients were actually traumatized, so to speak, by looking at their test results. It's not that these methods don't exist. They've been very well developed in the psychology field. They just haven't really been applied to this work. And there's not really a lot of information either about that longitudinal perspective. So a patient may be shocked to learn of something one day, but a week later, their distress may have subsided, or it may not. We just don't have those data right now. So again, the methods exist. They just haven't really been applied in this particular context. But I will show you a survey of patients who were asked about how much they worried after seeing their test result compared to beforehand. So how much were they worried, like when they were just waiting for it versus after they had actually seen it in the portal? And these are grouped by results that are normal and results that are not. And what you see here in this survey, and this was several thousand patients, but the patients were more worried, and I think that makes sense when they had received a not normal test result. But for the most part, they reported that they were either a lot less worried or they really weren't worried much to begin with, or there wasn't much change in their level of worry. And in qualitative work and some of the interview studies that we looked at in our review, we found that patients use the portal as a way of managing their anxiety. They were so anxious to hear back about their results, and when they got them, that helped to put their mind at ease, because the anticipation was the anxiety-provoking part, not the content of the test result itself necessarily. So what these findings show is that the patient portal can be a source of anxiety management as easily as it can be a source of anxiety or worry. There's been, to my knowledge, one study that has actually looked at documented adverse events that are specifically related to direct release of test results. And this was performed in the Netherlands at a large academic medical center, looking over 2 years' time at patient complaints, at safety event reports that were reported by staff at the medical center, by health IT help desk inquiries, and surveys of patients and clinicians. And they found 6 incidents that they really thought were actually directly attributable to having test results released in real time. But when surveyed, patients were mostly not concerned about getting upsetting news through the portal. They were concerned about not being able to get on the portal, having technical difficulties or access barriers, or finding incorrect information in the patient portal. That was what was upsetting. Whereas clinical staff were still concerned about, this may be very distressing to patients. This may be a concern if we don't have a provider on staff who's able to handle a patient's question in real time. And they also recognize that patients identified errors in the medical record. And this is sort of an understudied phenomenon. To put this into a little more context, this is a multinational study that was completed looking specifically at negative experiences related to patient access to their medical record. This wasn't just to test results, but this was related to patients accessing all of their health information. And the biggest concern was missing information. Patients thinking that there should be something about something that just happened to me in my medical record, and it wasn't there, or it was available too slowly. It wasn't being released yet. And again, these are not necessarily countries where direct immediate release is always the norm. But as you can see, that missing information was a big problem. And another negative experience that was also relatively frequent, more than 10% in a few countries, was patients finding errors in their medical record, and in some cases having trouble correcting them as well. We looked at, others have looked at patient complaints that may or may not be related to direct test result reporting, but this study looked at 8,500 or so patient complaints over a couple of years' time, just to see if the overall rate of complaints changed during that critical period when we moved to not having any information blocking or having patients be able to directly access their test results, and found that the rate of complaints overall really didn't change much. You see this little tick up here that I think is pandemic related. But overall, the rate of complaints didn't really change. There were a few complaints related specifically to test results, but overall not much. And perceptions of how safe and how problematic this is are also changing. We've only been able to find 2 studies that looked longitudinally at providers and staff attitudes, but what happened in both of these studies, which are limited by fairly modest sample sizes, but what we see is that these negative perceptions of test result release to patients have sort of been attenuated. In one case, in neonatal ICU clinicians and staff, positive benefits of test result release were also sort of downgraded a year after implementation. So, and with experience, it seems like both the anticipated highs and lows of direct test result release have sort of been tempered with time and experience. So it looks like both the safety advances and the safety concerns may not be as intense as anticipated. So in summary, just wanted to, again, reinforce the idea that we don't really have a lot of data on certain populations. We do kind of have oncology settings overrepresented because of this issue of cancer-related results being so top of mind. But we especially don't have a lot of good data on how to remove barriers to access and usability for socially disadvantaged groups, for folks who speak other languages than the dominant language of the healthcare system, and with older adults. And there are other populations, and I think we have to go into our communities and settings to figure out, in your setting, who are those people who are being missed and who are missing out on the benefits of being able to access their health information. We, again, really don't see the same intensity of harms or benefits that some folks had anticipated when we started to roll out direct test result release. And it's interesting that we can ask, we can anticipate, we can do lots of opinion surveys and interviews of what we think is going to happen, but really we need to look at the actual data. We need to see what patients are actually doing, the messages they're actually sending, which results they're actually looking at, and how many times and for how long. And these metadata are an interesting source of information about that. And even though we sort of anticipated that patients would be pretty distressed if they were seeing sensitive results in real time, we're not seeing a big signal that that's been a huge problem in any of the systems that we've interacted with, and nothing's really popping in the literature either. But that said, we're not measuring that distress in a way that's reliable or valid, and we're not measuring it longitudinally either. And so we could do a better job of that also. Patients and clinicians want a lot of the same things. We don't want a one-size-fits-all setting for test result release and notifications. We want that delivery of information to be patient-centered and accessible, and also have that clear action message. And because in the United States, a lot of the design and the use of portals are driven by private industry and companies that are selling their systems. We're sort of at the mercy of some of those organizations to take action and try to bridge that digital divide. And that's why I'm so excited to be partnering and collaborating with Dr. Watson and her team on the Accessible Results Project, because they're doing what we should have done in the US proactively, which is to really go out and engage folks who are likely to be affected by that digital divide, and to not only learn about their needs, but also start to incorporate them into tools that will hopefully narrow that digital divide and help people to make better use of the information that's coming through them to them through the portal. So that is all I had to tell you about today, but I wanted to take a moment and acknowledge our funding source for our review, the Agency for Healthcare Research and Quality, Baylor College of Medicine, the center where we work, iQuest, and also the Safer DX research team, and my mentor Hardeep Singh, who is seated there in the center. And my email address is in the top corner. If you're interested in reaching out, please do. And it looks like we have a little bit of time for some discussion and questions. And thank you very much.
Thank you so much. Do stay and I'll just stop sharing so that we can see any questions coming through. Firstly, in the room, any questions? That was an absolutely wonderful presentation. We might need to stand in this corner where we've got the mic, just for the
Sorry. I'll let you be in the spotlight.
yeah, any questions in the room? Matt?
Thanks for a lovely talk, really nice tour of the issues. It's all about context, though, isn't it? So it's the context of healthcare systems, the context of the test. Some tests clearly don't have, you need the interpretation, the context of the test.
Right, right.
That's what really shone through to me. And then, and in terms of the systems, there's so many. You've done a really good job of trying to review the literature, but it must be apples and pears, some of it.
Some of it is, right, because, you're trying to compare, for example, the US context to the Netherlands, they're different systems, they're different values sort of drive what innovations and policies are implemented. But I think that we've gotten away so far with being context free in the US, because again, a lot of the drivers of the patient portals that are available are not patient-centered, they are commercial drivers and policy drivers too. So it's what we've written into the law. There is nothing in the 21st Century Cures Act that says that the information blocking rule needs to ensure that patients are engaged equitably. Nothing in our law requires that to be the case. And in certain communities, I work in Houston, where we have a very diverse population, the most diverse urban area in the United States. So our patients come in and they speak Spanish, they speak Arabic, they speak Vietnamese. We serve a very diverse set of patients, and we know that only a segment of them are really able to benefit. I think this is where there may be some opportunities for AI-driven solutions. There are some nice studies. So, for example, like out of Yale Medicine and their radiology group, looking at AI-generated summaries for patients of radiology reports. That could potentially help with some language barriers as well. But it still requires humans to make sure that that works and is actually accessible and equitable.
Thank you. Fantastic. Do we have any questions coming up online? I'll try and work out how to do that. Not at the moment.
Things in the chat.
There's
Oh, there's Q&A. Okay.
Here we go. Here we go.
Mhm.
Great. So this is a question from Ross Pope. You mentioned reference ranges earlier on. We face some challenges there with there being real inconsistency with those ranges in England that can make interpretation confusing. Does that challenge exist in the US or other data quality challenges?
It does exist in the US, and this is where we, again, have the issue of multiple commercial entities. We have different labs that will run the same test and provide different reference ranges. How that gets filtered down to the patient depends on whether that lab has their own portal, which some do. Some have their own just portal for lab results because you get a private lab done. You don't get it done by Baylor College of Medicine. You get it done by something called LabCorp or, something like that. And so it is a problem. The other problem related to that is there has been, I'm really talking about patient-centered concerns. So I'm leaving out some important context, I think also about workload for clinicians, but people do have noticed that patients will write in because, their lab result may be 1 point above normal, and really it's clinically not significant, but it's concerning to the patient because they're just seeing whatever that portal is delivering to them. So there are challenges both with differing lab reference ranges. So it sounds like you have a similar issue here in England. But also that patients see that reference range and, they really have a lot of ambiguity around when things are just a little bit abnormal and how much urgency to ascribe to that.
Great. Well, I'm aware we're just 1 minute past 2 o'clock. So even though I've got half a dozen more questions to ask, I think we'll have to close it there. We'll just have a final thank you very much. That's been really fascinating.